midwifers, welcome back to my channel. We have started a series of guidelines which are from the RCOG GTG Green Top Guidelines, and today is the episode number 2. And this guideline is the cervical cerclage, which was published on June 2022, and it is GTG number 75. So let's start with the cervical cerclage. Again, the key recommendations are very important. So starting with the key recommendations, women with the singleton pregnancies and 3 or more previous preterm births, they should be offered a history indicated cervical cerclage. Women with the singleton pregnancy and a history of spontaneous second trimester loss or the preterm birth who have not undergone a history indicated cerclage may be offered serial sonographic surveillance, as those who experience a cervical shortening may benefit from the ultrasound indicated cerclage, while those whose cervix remains longer greater than 25 have a low risk of the second trimester loss or the preterm birth. For women with a singleton pregnancy and no other risk factors for the preterm birth, insertion of the cervical cerclage is not recommended in the women who have an incidentally identified short cervix. In women with the previous unsuccessful transvaginal cerclage, insertions of the transabdominal cerclage, they may be discussed and considered. In women with a singleton pregnancy, insertions of an emergency cerclage, they may delay the birth by an average of the 34 days, and compared with the expected management, bed rest alone in the suitable cases. It may also be associated with the twofold reduction in the chance of the birth before 34 weeks of the gestation. However, there are the only limited data to support an associated improvement in the neonatal mortality or morbidity. The choice of the transvaginal cerclage technique, high cerclage insertion with the bladder mobilization or the low cervical insertions, they should be at the discretion of the surgeons, but the cerclage, they should be placed as high as in a practically possible. So we don't need to do the background and scopes. And cervical insufficiency, again not. Okay. Again, the identification and assessment of the evidence, you don't need to do that. Yes, definitions are important, so start with the definitions. The previous terminology: prophylaxis as a planned procedure, emergency urgent rescue of a cervical sutures, cerclage, they can be ambitious and more appropriate nomenclature based on the indication of the cervical suture is recommended. The term below are increasingly used in a scientific literature. History indicated cerclage, the insertion of cerclage as a result of the factors in a woman, obstetric or the gynecological history, with which increases the risk of the spontaneous second trimester loss or the preterm birth. A history indicated suture is performed as a prophylactic measures in asymptomatic women and usually inserted as a planned procedure at the 11 to 14 weeks of the gestation. Preterm birth, the birth before 37 weeks of the gestation. Ultrasonographic indicated cerclage, insertion of cerclage as a therapeutic measure in the cases of the cervical length shortening seen on the transvaginal ultrasonography. Ultrasonography indicated cerclage is performed on asymptomatic women who do not have exposed fetal membranes in the vagina. Sonographical assessment of a cervix is usually performed between the 14 to 24 weeks of the gestation by the transvaginal scan and with an empty maternal bladder. Emergency cerclage, also known as a physical exam indicated or the emergency cerclage, insertion of cerclage as a salvage measures in the case of the premature cervical dilatation with exposed fetal membranes in the vagina. This may be discovered by ultrasound examination of the cervix or as a result of the speculum physical examination performed for the spontaneous, such as the vaginal discharge, bleeding, or sedation of the pressure. It can be considered up to 27 plus 6 weeks of the gestation. Transvaginal cerclage, which is also known as the McDonald, transvaginal purse string suture placed at the cervical isthmus junction without the bladder mobilization. High transvaginal cerclage requiring the bladder mobilization, including the Schroeder. A transvaginal purse string suture placed following the bladder mobilization to allow the insertion above the level of the cardinal ligament. Transabdominal cerclage is a suture performed by a laparotomy or laparoscopy, placing the suture at the cervicoisthmus junction. Occlusion cerclage, occlusion of the external os by the placement of the continuous non-absorbable suture. The theory behind the potential benefit of the occlusion cerclage is a retention of the mucus plug. So, what should a history indicated cerclage be offered? Or when should the history indicated cerclage be offered? This is important. Women with the singleton pregnancies and 3 or more previous preterm birth, they should be offered a history indicated cervical cerclage. And here is a recommendation: you don't need to do this at this time of the when you're preparing for the exam, but if you have time, do read it at once. Then next, the history indicated cerclage, they should not routinely be offered to a woman with the less than 3 previous preterm births and or the second trimester losses without additional risk factors. It is unknown if the specific characteristics of a previous adverse event are helpful in the decision to place a history indicated cerclage. For example, painless dilatation, rupture of the membrane, and prior cervical surgery. Okay, we don't need to do this part of the guideline and not do this. Now the next is the ultrasonography or ultrasound indicated cerclage. When should ultrasound indicated cerclage be offered? For a woman with a singleton pregnancy and or no other risk factors for the preterm birth, insertion of the cervical cerclage is not recommended in the women who have a short cervix incidentally identified on the late second trimester ultrasonography scan. This is the evidence level 1 plus plus, and this is evidence level 1 again 1 plus plus. So next is the women with a singleton pregnancy and a history of the spontaneous second trimester loss or the preterm birth. And the recommendation is the women with a history of one or more spontaneous second trimester losses or the preterm birth who are undergoing the ultrasonography surveillance of the cervical length should be offered cerclage if the cervix is 25 or less at the gestation less than 24 weeks. An ultrasonography indicated cerclage is not recommended for the funding of the cervix, dilatation of the internal os, and the ultrasonography in the absence of the cervical shortening of 25 or less, the closed length of the cervix. Okay, this evidence level again 1 plus plus, and this is again the evidence level 1 plus, and these are 2 plus plus. So next is who should be offered serial sonographic surveillance with a view or to the ultrasonography indicated cerclage. The recommendation is women with the history of the spontaneous second trimester losses or the preterm birth who have not undergone a history indicated cerclage may be offered serial sonographic surveillance, as those who experience the cervical shortening less than the 25 may benefit from the ultrasonography indicated cerclage. Okay, here it is important that the serial sonographic surveillance, they may differentiate between the women with the prior second trimester loss, preterm birth, and who might benefit for the cerclage, and the women who do not intervene. Similarly, in these studies, here is the recommendation that the woman with the previous second trimester loss, preterm birth, they can safely cared for the serial ultrasonography surveillance, and that this may reduce the number of the cerclage performed. Ultrasonography surveillance of the cervical length is advocated in a woman with a high and intermediate risk of the element 5 of the Saving Baby's Life Care Bundle, the time of which is dependent on the women's history. Women at the high risk includes those with the previous preterm birth or the second trimester loss, and the previous preterm pre-labor rupture of the membrane, and previous use of the cerclage, and non-uterine variant, and the intrauterine adhesions. And if they have the history of the trachelectomy, and these women are recommended to be reviewed by a preterm prevention specialist by 12 week when possible, on with a dating scan, whichever is sooner, and offer the transvaginal cervix scanning as a secondary screening test. Women at the intermediate risk includes the women including those who have a history of the previous full dilatation cesarean sections and the significant cervix excisional surgery, such that the large loop excisions of the transformational zone and with an excision depth greater than 1 centimeter, more than one procedure, or a cone biopsy. This is how uncertainly or to how to care for these women if the short cervix is identified in the women who have had the serial screening but do not have the history of the previous preterm birth, and the ultrasonography indicated cerclage, they may be considered. Now, can the cervical cerclage be recommended in any other group of the women considering at increased risk of the preterm birth? So the number one is the multiple pregnancies, and the insertion of the history or the ultrasonography indicated cerclage in the women with the multiple pregnancies is not recommended. Okay, this is analysis. You can leave it, evidence levels, but if you have time, go and get a read at once. Okay. And so next, move to the cervical surgery, trauma, and the uterine abnormalities. And what is the recommendation? The role of the history or the ultrasonography indicated cerclage is uncertain in other high risk groups who display no additional risk factors, such as the women with the Mullerian anomalies and previous cervical surgery, cone biopsy, LLLs, or the destructive procedures such as the laser ablations or the diathermy or the multiple dilatation and the evacuation. And this is again the evidence level. You can read them, but at this time we can leave them. Okay. Next is the recommendation in the women with the raised BMI. The cerclage is effective in the women with the raised BMI, and here the results was driven by several women with an extremely high BMI. And then the transabdominal cerclage. When should the transabdominal cerclage be considered? In a women with the previous unsuccessful transvaginal cerclage, insertions of a transabdominal cerclage, they may be discussed and considered. Transabdominal cerclage, they can be performed pre-conceptually or in the early pregnancy, and preconceptual procedures, they may be more effective and are not associated with the subfertility. Again, this is the evidence level. You can do them if you have time. Next, should an abdominal cerclage be performed laparoscopically? Yes, laparoscopy and the open abdominal cerclage, they have the similar efficacy. The laparoscopic approach is associated with the fever complications, and they can be considered when the suitable surgical expenses is available. Okay. Now let's move next. Here, the meta-analysis comparing the laparoscopy versus the open abdominal cerclage found no difference in the third trimester birth or the live birth rates. Okay, now next, how should the women who experience delayed miscarriage or the fetal death be cared for? Decisions on the care and the treatment in cases of the delayed miscarriage or the fetal death in the women with the abdominal cerclage, they can be difficult, and the women decision making, they should be aided by a senior obstetrician, and the complete evacuation through the stitch by the suction and curettage, or by the dilatation and the evacuation up to 18 weeks of the gestation may be performed. Alternatively, the suture, they may be cut, usually via posterior colposcopy, and failing this, the hysterectomy, they may be required, or the cesarean section may be necessary. The women, the decision, they should be aided by the senior obstetrician. And here it is important that you should know the cares, they should be aware of the potential psychological sequel associated with the fetal death and the miscarriage, and the women with their families supported by the debriefing service and the offer of the counseling. The families, they should be signposted to the relevant patient support groups. Okay, now what is the emergency cerclage, and what is its importance? So when should a rescue cerclage be discussed and considered? The decision to place an emergency suture, they should be individualized and taking the parents' views carefully into the account. The balance is between a useful prolongation of the pregnancy with its reduced neonatal morbidity and mortality against the possibility of the prolonged severe neonatal morbidity in a baby that might otherwise die. The women decision, they should be aided by a senior obstetrician, and insertion of the emergency cerclage, they may delay the birth by the approximately 34 days in a suitable cases, and compared with the expectant management bed rest alone. It may also be associated with the twofold reductions in the chances of the birth before 34 weeks of the gestation. However, they are the only limited data to support an associated improvement in the neonatal mortality or morbidity. Advanced dilatation of the cervix, the more than 4 centimeter, or the membrane prolapse beyond the associated with the high chances of the cerclage failure. There is no clear evidence that the gestation at the cerclage is inserted affects the magnitude of the prolongation of the pregnancy. However, consideration they should be given to the fact that in the cases persisting before the 20 week of the gestation, insertion of the emergency cerclage is highly likely to result in a preterm birth before 28 weeks of the gestation. And furthermore, an emergency cerclage, they can rarely be justified beyond the 24 weeks gestation due to the potential risk of the iatrogenic membrane rupture and the subsequent preterm birth. So what are the contraindication to the cerclage insertion? The recommendation, the contraindication to the cerclage insertions are the active preterm labor and the clinical evidence of the chorioamnionitis and the continuous vaginal bleeding, PROM, and evidence of the fetal compromise and the lethal fetal defect and the fetal death. What information they should be given to the women before the cerclage insertion? Before the history or the ultrasonography indicated cerclage insertion, the women, they should be given the verbal and the written information about the potential complication. Before any type of the cerclage insertion, the women, they should be informed of the following. There is a small risk of the intraoperative bladder damage and cervical trauma and the membrane rupture and bleeding during the insertion of the cervical cerclage. Cervical cerclage may be associated with the risk of the cervical laceration stoma if there is a spontaneous labor and with the sutures in place. High vaginal cerclage, the insertion with the bladder mobilization usually requires an anesthesia for the removal and therefore carries the risk of the additional anesthesia. For the women undergoing the non-emergency cerclage, the vaginal cerclage, the insertion is not associated with the increased risk of the prom, chorioamnionitis, inductions of the labor or the cesarean section. The insertion of the cervical suture is not associated with the increased risk of the preterm birth or the second trimester loss, and the cervical cerclage, they may be associated with the risk of cervical laceration trauma if there is a spontaneous labor with the suture in place. So these are the rationales of the recommendations. If you want to do it, you can do it, otherwise you can leave them. Okay, what is this 2 minus 2 minus 4, 1 plus 1 plus and 1 plus d gpp b. I have made another video for this. These are the level of the evidences as well as the grade of the recommendations and the good practice points. If you want to know detail about this, visit my video. Thank you. So let's continue with our evidences. And here the important thing is that intraoperative complications, including the bladder damage, cervical trauma, membrane rupture, and the bleeding, are reported but are rare. Fistula formation has been reported or as a rare complication. Similarly, let's move towards the preoperative management. What investigation they should be performed before the insertion of the cervical cerclage. The women, they should be offered a first trimester ultrasonography scan and the screening for the aneuploidy before the insertion of the history indicated suture to ensure both the viability and singleton pregnancy and the present absence of the lethal major fetal anomaly. And before the ultrasonography indicated or the emergency cerclage, it is preferable to ensure an anomaly scan has been performed. Maternal white cell count and C-reactive protein to detect chorioamnionitis before the insertion of emergency cerclage. They can be used to aid management. The decision to perform these tests, they should be based on the overall clinical picture, but in the absence of the clinical sign of the chorioamnionitis, the decision for the emergency cerclage need no delay. Okay, let's continue with the next topic, that is the should the amniocentesis to detect infection be performed before the rescue on the ultrasonography indicated cerclage. There is insufficient evidence to recommend the routine amniocentesis before the rescue or the ultrasonography indicated cerclage, as there is no clear data demonstrating the improved outcome. In selected cases, when there is a suspicion of the intra-amniotic infection, amniocentesis they may be performed to aid the decision about the emergency cerclage, as the presence of the infection is associated with a poor prognosis, and amniocentesis before the emergency cerclage they does not appear to increase the risk of the preterm birth before 28 weeks of the gestation, but this is likely to be some risk to form the procedure. Okay, so let's continue. Is the amnio reduction before the emergency cerclage recommended? The recommendation, there is an absence of the data to either the refute to support the use of the amnio reduction before the insertion of the emergency cerclage, and this should therefore not be carried out. And it is impossible to draw an evidence-based conclusion as it is contribute to the outcome, as the several small studies have reported the successful prolongation of the pregnancy using amnio reduction before the cerclage, and it has evidence level 3. Should a latency period be observed between the presentation and insertion of the rescue on the ultrasonography indicated cerclage, and each cases they should be managed on an individual basis. And so should routine genital tract screening for the infections be carried out before the cerclage insertion, and routine genital tract screening they should not be undertaken before the cerclage insertion in the presence of a positive culture from a genital swab. Antimicrobial therapy they should be decided on an individual basis after the discussion with the microbiology team. And what are the operative issues for the cervical cerclage? Number one is that should the perioperative tocolysis be used for the insertion of the cerclage? There is no evidence to support the use of the routine perioperative tocolysis in a woman undergoing the insertion of the cerclage. This should be considered on an individual basis. Then should perioperative antibiotics be given? The decision for the antibiotic prophylaxis at the time of the cerclage placement. They should be at the discretion of the operative operation team. And what method of the anesthesia they should be employed for the insertion of the cerclage, and the choice of the anesthesia they should be made by the operating team in the conjunction with the women. And can the cerclage be performed as a day care procedure? Elective transvaginal cerclage they can safely be performed as a day care procedure. And what techniques and the material should be used? The choice of the suture material they should be at the discretion of the surgeon, and non-absorbable suture they should be used. The choice of the transvaginal cerclage, the technique, and the high cervical insertion with the bladder mobilization or the low cervical insertion they should be at the discretion of the surgeons, but the cerclage they should be placed as high as is practically possible. There is no difference between the using the two purse string sutures and one single suture, and should be at the discretion of the surgeons. And the insertion of the evidence occlusion suture in the addition to the primary cerclage is not routinely recommended. There is insufficient evidence to support any specific technique for the cerclage insertion. And um, what are the adjuvant management? And number one is the bed rest. The bed rest in the women who have undergone the cerclage, they should not be routinely recommended, but they should be individualized and taking into the account the clinical circumstances and potential adverse affects the bed rest. In addition, to increase the cost for the healthcare system, and the sexual intercourse and the abstinence from the sexual intercourse the following cerclage insertion they should not be routinely recommended. And while the routine serial sonographic measurement of the cervix is not recommended, it may be useful in the individual cases following the ultrasonography sound indicated cerclage to offer the timely administrations of the steroids or into the utero transfer in the presence of the history indicated cerclage. Additional ultrasonography indicated cerclage is not routinely recommended as compared with the expectant management. It may be associated with an increase in the both the pregnancy loss and the birth before 35 weeks of the gestation. The decision to place emergency cerclage following an elective or the ultrasonography indicated cerclage they should be made on an individual basis, taking into the account the clinical circumstances. And is the fetal fibronectin test is useful following the insertion of the cervical cerclage? Routine fetal fibronectin testing is not recommended, and post cerclage, however, the high negative predictive value of the fetal fibronectin testing for the subsequent birth at the less than 30 weeks of the gestation in the asymptomatic high risk women with cerclage in the place may provide the reassurance to the women and the clinicians in the individual cases. So, should the women they receive the supplements progesterone following the cerclage? Routine use of the progesterone supplementation they following the cerclage is not recommended. And should the women be offered an Arabian pessary or the progesterone instead of the cerclage? There is no evidence that either the progesterone or the Arabian pessary alone are the more or less effective than the cervical cerclage itself. So when should the cerclage be removed? A transvaginal cerclage, cervical cerclage, they should be removed before the labor, usually between the 36 plus 1 and the 37 weeks, the weeks of the gestation, and unless the birth is by the pre-labor cesarean section, in which the case the suture and removal they should be delayed until this time. In the women they presenting in the established preterm labor, the cerclage they should be removed to minimize the potential trauma to the cervix. A high inserted with the bladder mobilization, the cervical cerclage they will usually require the anesthesia for the removal. All women with the transabdominal cerclage require the birth by the cesarean birth, and the abdominal suture they may be left in the place following the birth. So, should the cerclage be removed following the prom? In the women with the pre-prom, the between the 24 to 34 weeks of the gestation and without the evidence of the infections or the preterm labor, the late removal of the cerclage for the 48 hours they can be considered to facilitate the utero transfer, and delayed suture removal until the labor ensures or the birth is indicated in the associated with an increased risk of the maternal fetal sepsis and is not recommended. Given the risk of the neonatal and the maternal sepsis and the minimal benefits of the 48 hours of the latency in the pregnancy with the PPROM before 23 and after the 34 weeks of the gestation, delayed suturation should be is unlikely to be advantageous in this situation. So we don't need to do the recommendations for the future research, and then suggested audit topic more, and useful links and supports are given, and there's a supporting information and there's a reference given. So this concludes our guideline, which is GTG 75, and this is the cervical cerclage. And I hope you like the video, and stay tuned for the further and future guidelines. Take care till next time. Take care.